Welcome to From Literature to Bedside. Today, we take a single anatomical segment, the mid-thoracic esophagus, and follow it from its defining landmarks through to stage-specific management. It is a deceptively precise topic because in the esophagus, location dictates the biology, the nodal spread, the operation, and even the stage group. By the end, you will be able to place a tumor exactly, predict its nodal basins, and choose treatment on evidence. Esophageal carcinoma is the sixth commonest cause of cancer mortality worldwide. In the thoracic esophagus, and especially the middle third, the dominant histology is squamous cell carcinoma. In contemporary superficial cancer series, the mid-third accounts for roughly two-thirds of squamous lesions. Most patients present late, with progressive dysphagia and weight loss. In mid-thoracic disease, a cough on swallowing or hoarseness should immediately raise airway invasion or recurrent laryngeal nerve involvement. The AJCC 8th edition classifies by the location of the tumor epicenter measured endoscopically from the incisors. The middle thoracic esophagus lies between two venous landmarks, the lower border of the azygos vein above at about 25 centimeters and the lower border of the inferior pulmonary vein below at about 30 centimeters. Above the azygos is upper thoracic, below the inferior pulmonary vein, lower thoracic, and then the junction at 40 centimeters. Why insist on this position? Because level drives five things: the likely histology, the nodal basins at risk, the relationship to the airway, the operation if one is offered, and, for squamous carcinoma alone, the stage group itself. In the 8th edition, a PT3N0 squamous tumor is stage 2A in the lower esophagus but stage 2B in the middle or upper. We will take these in turn. Histology first. Squamous cell carcinoma dominates the cervical, upper and middle thoracic esophagus. Adenocarcinoma dominates the lower esophagus and the junction arising from Barrett metaplasia. This is not academic pedantry. It determines the entire systemic therapy strategy and, as we shall see, it means the large adenocarcinoma trials do not transfer to a mid-esophageal squamous cancer. The T category tracks depth. T1A is confined to the mucosa. T1B breaches the submucosa. T2 invades the muscularis propria. T3 the adventitia. T4 invades adjacent structures. T4A the pleura, pericardium or diaphragm, still resectable. T4B the aorta, vertebral body or airway, unresectable. That T4B airway distinction is precisely where the mid-thoracic location becomes decisive. The nodal category, crucially, is defined by the number of positive regional nodes. 1 to 2 is N1, 3 to 6 N2, 7 or more N3, not by their location. Two consequences follow. First, an adequate lymphadenectomy is essential simply to stage the patient. Second, supraclavicular nodes are classified as distant metastasis, M1, a reminder of just how far the esophagus drains. Now, the reason nodal disease is so treacherous here. The esophagus carries a rich submucosal lymphatic plexus running longitudinally. So tumor travels far from the primary and produces skip metastases that bypass adjacent nodes. Drainage is bidirectional, cephalad to the neck and superior mediastinum, and caudad to the abdomen. For the mid-thoracic tumor, the lymph preferentially ascends through the wall to the superior mediastinum. Here is the station map in the Japanese nomenclature. In the neck, 101 paraesophageal and the supraclavicular 104, now counted as M1. In the superior mediastinum, the recurrent laryngeal nerve nodes 106 rec, right and left, then the thoracic paraesophageal chains 105, 108 and 1010 for upper, middle and lower, the subcarinal 107, and inferiorly the paracardial and left gastric and celiac nodes. The AJCC map divides the same territory by airway landmarks rather than by nerve, which complicates cross-study comparison. For the middle third specifically, the metastatic hierarchy is striking. The highest incidence of nodal disease is in the upper mediastinal recurrent laryngeal nerve nodes, the 106 rec stations, followed by paracardial, supraclavicular, and subcarinal nodes. A tumor at 27 centimeters therefore seeds nodes at the thoracic inlet and in the abdomen simultaneously. This is the anatomical case for clearing the upper mediastinum even in a mid or lower third cancer. Does that mean everyone needs a 3-field dissection, adding the cervical fields to the standard 2-field abdominal and thoracic clearance? A 2026 meta-analysis of over 10,000 patients answered carefully. 3-field surgery harvests about 15 more nodes, but confers no significant overall or disease-free survival benefit, while roughly doubling recurrent laryngeal nerve palsy and pulmonary complications. The lesson is selective, risk-guided upper mediastinal dissection, not routine 3-field surgery. The airway relationship earns its own slide. The mid and upper thoracic esophagus lies directly against the membranous trachea, the carina, and the left main bronchus. Invasion makes the tumor T4B, and a tracheo-esophageal fistula is both a contraindication to surgery and a lethal complication. This is why guidelines mandate bronchoscopy for any tumor at or above the carina, which is precisely the mid-thoracic patient. Clinically then, progressive dysphagia from solids to liquids and weight loss are the cardinal features and usually signal locally advanced disease. Hoarseness implies recurrent laryngeal nerve involvement, a cough on swallowing suggests a fistula, aspiration pneumonia and supraclavicular adenopathy may be the presenting events. None of these is subtle, which is much of the tragedy of this disease. Staging follows the current NCCN framework. Endoscopy with biopsy documents histology and the distance from the incisors. Endoscopic ultrasound with fine needle aspiration is the most accurate test for TNN. CT of chest and abdomen and FDG PET CT from skull base to mid-thigh exclude distant disease. And PD-L1 testing is now recommended in all patients because it governs first-line immunotherapy. Two additions matter for our patient. Bronchoscopy, as we said, for any tumor at or above the carina. Staging laparoscopy is reserved largely for junctional adenocarcinoma with peritoneal risk and is low yield in mid-thoracic squamous disease. And a formal assessment of fitness, nutrition, performance status, cardiopulmonary reserve, because the treatments we are about to discuss are demanding. To management by stage. For carcinoma in situ and T1A mucosal disease, endoscopic resection, preferably submucosal dissection for an en-bloc specimen, is the organ-preserving treatment of choice, provided the lesion is mucosal, well or moderately differentiated, and free of lymphovascular invasion. This spares the patient an esophagectomy entirely. Once tumor reaches the submucosa, T1B, or the endoscopic specimen shows lymphovascular invasion, poor differentiation, or a positive margin, the risk of nodal metastasis rises steeply, more so in squamous than in adenocarcinoma, and esophagectomy becomes the standard. Which brings us to the operation itself. 3 approaches. The McEwen or 3-incision oesophagectomy. Abdomen, chest and neck with a cervical anastomosis is generally preferred for mid and upper third tumors because it affords a generous proximal margin and access to the upper mediastinal nodes. The Iward-Lewis with an intrathoracic anastomosis suits lower third and junctional tumors. The transhiatal approach avoids the chest altogether. For our mid-thoracic patient, the choice usually falls on McEwen. Is more surgery better? The definitive Dutch randomized trial compared transhiatal with extended transthoracic resection. Overall, there was no significant survival difference. 5-year survival 34 versus 36%, and transthoracic surgery carried more pulmonary morbidity. But in the subgroup with 1 to 8 positive nodes, extended transthoracic resection gave a striking advantage, 64 versus 23%. The extent of surgery should therefore match the nodal burden, not be maximal by default. How the operation is done matters as much as its extent. The TIME trial showed that minimally invasive esophagectomy cut pulmonary infection from 29 to 9% with equivalent nodal yield and oncological outcome. The robot trial showed robot-assisted surgery reduced overall complications 59 versus 80% with fewer pulmonary and cardiac events. Minimally invasive access is now the default in capable hands. 2 caveats the resident should carry. A cervical anastomosis, the one we accept for a mid-thoracic McKeown, leaks about 3 times as often and injures the recurrent nerve 6 times as often as an intrathoracic joint. But a neck leak is usually less lethal, so 30-day mortality is comparable, and the choice is driven by tumor level, not leak rate. And outcomes track volume. High volume centers have materially better long-term survival. Hazard ratio about 0.77. This is an operation for specialized units. On the nodes themselves, the Worldwide Esophageal Cancer Collaboration linked survival to nodal yield, recommending roughly 10 nodes for PT1, 20 for PT2, and 30 or more for PT3 to 4. Recurrent laryngeal lymph node dissection is high yield in mid and upper squamous cancer, but carries a real risk of nerve palsy, so it is best applied selectively, guided by tumor depth and location, the recurring theme of this talk. For locally advanced resectable disease, T2 and above or node positive, the first standard is trimodality. Neoadjuvant chemoradiotherapy, then surgery, the cross regimen of weekly carboplatin and paclitaxel with 41.4 Gray. At 10 years, the benefit persists, and it is greatest in squamous carcinoma, 46 versus 23%. For a fit mid-oesophageal squamous cancer, this is a standard of care. But surgery is not obligatory in squamous disease. Definitive chemoradiation is a co-equal curative option, the preferred one for cervical and upper tumors, the medically inoperable or by patient choice. 2 randomized trials, STAL and FFCD 9102, showed that adding surgery after chemoradiation improves local control but not overall survival at the cost of higher treatment-related mortality. In a responder, continued chemoradiation is entirely legitimate. The chemoradiation itself is well defined. RTOG 85-01 established cisplatin and fluorouracil with radiotherapy over radiotherapy alone. 5-year survival 26 versus 0%. The standard dose is 50.4 Gray. The ART-DECO trial showed that escalating to 61.6 Gray adds nothing. Folfox is an accepted alternative to cisplatin fluorouracil. More radiotherapy is not better radiotherapy. A vital caution. For adenocarcinoma, the Esophagus trial has moved the standard to perioperative FLOT chemotherapy. But Esophagus enrolled adenocarcinoma only and must not be extrapolated to squamous disease. For squamous cancer, the frontier is neoadjuvant immunotherapy. The phase 3 ESCORT-NEO trial roughly tripled the pathological complete response rate by adding a PD-1 inhibitor to neoadjuvant chemotherapy without compromising surgery, promising but not yet standard. After trimodality, one more decision. If the resection specimen shows residual disease, a non-complete response, adjuvant nivolumab for 1 year doubled disease-free survival, 22 versus 11 months in the Checkmate 577 trial with benefit in both histologies. It is now standard for the non-responder after neoadjuvant chemoradiation and surgery. For metastatic squamous disease, first-line therapy is now chemotherapy plus a PD-1 inhibitor. Keynote Percent 590 and Checkmate 648 both showed survival gains greatest at higher PD-L1 expression, which is why we test it up front. This is a genuine, if modest, advance in a disease that long had none. Two final notes. For dysphagia palliation, a self-expanding metal stent gives rapid relief, while brachytherapy gives more durable relief in patients with a longer prognosis. And an idea worth watching. The SANO trial found active surveillance after a clinical complete response to chemoradiation, non-inferior at 2 years to immediate surgery. Organ preservation may be coming to squamous disease, but for now it belongs in expert centers and trials. To draw it together, stage the patient thoroughly, bronchoscopy if at or above the carina, TIS or T1A, endoscopic resection, early invasive, esophagectomy, MEC-Keon for the mid-third, locally advanced squamous, tri-modality or definitive chemoradiation, a genuine choice, residual disease, adjuvant nivolumab, T4B or metastatic, chemoradiation or systemic therapy with immunotherapy. Every branch is evidence anchored. The take home is a single idea. In the esophagus, where the tumor is, tells you what it is, where it will spread, how you would operate, and how it is staged. Master the landmarks and the nodal map, and the management follows logically. For the mid-thoracic squamous cancer, that means respect the airway, respect the upper mediastinal nodes, and remember that surgery and chemoradiation are co-equal paths to cure. That was Carcinoma of the mid-thoracic esophagus, from literature to bedside. I am Gautham Krishnamurthy. Thank you for watching.